And we have a presentation this afternoon. And so I'm going to call on those speakers first, Dr. Holborn and Jill Wolf. And Dr. Holborn is the Chief Epidemiologist and Surveillance Branch Division of Viral Hepatitis at the U.S. Centers for Disease Control and Prevention. And Ms. Wolf is the Hepatitis Program Director at the Caring Ambassadors Program. If you all want to tell us any more about what you do or everything, that'll be great. So I'll turn it over to you.
Thank you very much.
Have you got it on? Wait a second. Let's see if it sounds. Okay. There we go. Is it on? What was it, 2 or 1? It's 2. Sorry. I don't usually run this machine. Now try.
Okay. Yeah, that's working.
Hit the...
No?
Hit the button on the
It is not. Oh, it is on.
flip it the other way.
I've turned it back on again. The light's there.
Is that as loud as it
Okay,
goes?
good.
Okay.
Thanks.
Okay.
Well, I speak loud, so I don't think you're going to have any trouble hearing me. And we have very, very limited time to go over a number of facts about hepatitis C. I was asked to talk about viral hepatitis, give you a 101 course in 10 minutes. It's absolutely impossible. I'm going to be going over an awful lot of information, and you won't be able to absorb it all. That's why I'm glad some of it's written down. And we're going to ask that after we're finished talking, we'll be able, we'll open the floor up for discussion, and it's an awful lot of information to cover. I'm going to briefly mention that hepatitis A virus, which is something you can be vaccinated against, is a foodborne and waterborne infection. We still have some outbreaks, but the number of new infections with hepatitis A virus are going down in the United States over the last many years. Hepatitis B virus is of particular concern for many Asian Americans, and Pacific Islanders who live in the United States, who may have been infected with hepatitis B from mother to infant transmission and may now still be chronically actively infected with hepatitis B. There are about 1 million of those. And I want to swing immediately into our discussion about hepatitis C. I'd like, if you could please think of this as two issues. One is acute hepatitis C. That means new infections with HCV, as we say, hepatitis C. And the other is chronic hepatitis C. These are long-standing active infections. About 80% of acute infections in adults or children become chronic infections over a long period of time. I want to talk about acute hepatitis C. Until a few years ago, we had seen all the cases reported to us, which is only 8% of all the cases we think are happening nationally, had declined and actually plateaued. And after 2010, 2011, 2012, we've seen a real marked increase, almost a 80% increase in the number of cases of acute hepatitis we're seeing. We've been working for a few years in multiple places and are documenting now that this recent increase is almost entirely the result of young, white, non-urban, rural Appalachian, suburban, I want to say kids, who inject drugs, who initially started using oral prescription opioid drugs such as OxyContin and oxycodone before transitioning to something which is much more available and cheaper, heroin, which they are now injecting. And they're now getting infected with hepatitis C as well. This increase is detected in rural Georgia. I know this map isn't very good, but I think you can see where Georgia is, and the yellow and red indicate. You'll notice Atlanta isn't here showing the increase. It's mainly your northern and southern rural counties. We're updating this map with 2012 data and may show this even more. So that's one problem. The other problem is huge. It's chronic hepatitis C. We think over 3 million U.S. residents are living with chronic hepatitis C infection. Some of these data are controversial and just coming in, but I think you can believe me when I say tens of thousands of people are dying with and from hepatitis C. Those who are dying from hepatitis C are dying at an average age of 59 years old, so much younger than the normal lifespan. Although most people were infected from prior injection drug use, and some from blood transfusions before we had a screening test available to screen blood in 1992. But distressingly, I think there are quite a number, we've documented a number of outbreaks in clinical and hospital settings that are hard to detect. All right, there are a number of barriers to understanding the true nature and scope of this huge epidemic. One is the nature of the infection. Most people are infected 2 to 3 decades. They can live for a long time with no or non-specific symptoms such as depression, fatigue, nausea, and joint aches before developing end-stage liver disease or liver cancer. And they may not be aware they're hepatitis C infected until it's, well, too late or almost too late. There are limited resources dedicated to this large problem at both a federal and local level. There are splintered treatment venues. I think we can all think of HIV clinics, tuberculosis clinics, STD clinics, as we have in this state. But it would be very hard for you to name a hepatitis clinic in this state, although there is one unit at Grady which is dedicated to that, apparently. Hidden populations. Most people, if they're infected by injection drug use, are not going to want to step forward and say that, even if they've long since recovered, many people are not going to want to step forward and say how they got infected with hepatitis C. And then, as I mentioned, many people are percolating their infection and just don't know that they're infected because they may have gotten infected from a transfusion or in a clinical setting where this shouldn't have occurred. I think that this is a very exciting time because of the new therapies coming out, but as I point out, the sofosbuvir, which you may have heard about, this wonder drug for hepatitis C, it's a great treatment, in my opinion, but it costs $1,000 a pill, and a 12-week treatment cost is $84,000 right now just for that one pill alone. So cost is one problem, but I'd like you to look at the chart below. And as you can see, we have problems all along the treatment continuum for hepatitis C. So we start off with 3 million people who are living with hepatitis C. Only half of them have actually been tested and diagnosed, we think.
Excuse me just a minute. Do we have something? Has it been passed out? It's in the red folder.
I'm sorry.
It's all right.
It's 70% of them may have been actually gotten forwarded or referred to hepatitis C care. These are the hepatitis C RNA is an index of whether people are actually being tested for hepatitis C, and you can see fewer of them are tested. Then if people are tested, there may be many barriers to their getting treatment. It's not just cost. Some of these people have many other issues in their life, both medical and personal, or the doctor may not be taking this infection quite as seriously as we would wish him or her to, and so that patient doesn't really get in, for whatever reason, doesn't get into care and treatment. And then when you actually look at the number of people who've been treated, an SVR in this chart means cure. It stands for sustained virologic response, but it really means cure. Only 6%, we think, of the 3+ million people out there have actually been treated and cured. And let me just add that there's a misperception. Every time I talk about hepatitis C virus, I always hear, oh, well, that's just in drug users and they're dying of other things. Please let me inform you that, in fact, only 1 or 2% of all our hepatitis C infected people are dying from injuries, infections, or overdosage from drug use. In terms of prevention efforts, good, I'm staying on time. In terms of prevention efforts, I think that in this continuum of care right above there, I think any interventions anywhere along that continuum would have a wonderful, positive effect, beneficial effect on this outbreak, on this epidemic. Particularly increased efforts to identify people who are infected and to identify injection drug users, particularly these young, white, rural injection drug users, get them tested and linked into treatment for their addiction, obviously, and also for their hepatitis C care. I want to point out that this epidemic that I showed on the map mainly in the eastern. You'll notice it's mainly in the Appalachian states. Much of this, until 3 years ago, was fueled by the many, many walk-in pain clinics in Florida. Florida, as I understand, and I'm reading the same newspaper articles you are, Florida apparently regulated those clinics and severely regulated them and pulled them down. And now, guess where a lot of those walk-in pain clinics have moved? Georgia has had a real increase in the number of these pain clinics. So this may be something where you would want to look into and see if it would be appropriate for you folks to consider and legislate. In terms of chronic hepatitis C, our big push recently has been, since 75–80% of our cases have occurred in the birth cohort, the baby boomers born between 1945 and 65, we've recommended that all of us in that age group be tested and screened for hepatitis C at least once in our lives. Screening for this birth cohort is now mandated by the state legislature in New York, and there's pending legislation in Florida, New Jersey, Maryland, and Pennsylvania. And so that's something else that this legislature may want to consider. And then finally, I don't have time to go into all the state and federal efforts, including some limited efforts here in Georgia to improve testing, linkage to care, and access to treatment. I've listed our website at the beginning of this. They've taken away my email address, but it's on another sheet. But you'll be able to contact me if I've covered so much material. Thank you.
Thank you, Madam Chairwoman and committee. My name is Jill Wolfe. I hail from an organization called the Caring Ambassadors Program. We're national in nature. We work to empower people to be ambassadors of their own health. I am a clinical social worker, and I come with experience as a psychotherapist and with addictions treatment, trauma survivors, sex workers, ultimately working within the infrastructure of public health. So I'm here, again, to emphasize a lot of what's going on the ground and the real picture from the patient advocate perspective in hepatitis C. I do want to emphasize the fact that the data that we do have based on CDC is conservative estimates based on our NHANES data, our household survey. And so the numbers that we are giving you are extremely conservative, because the fact is many people, let's talk about baby boomers, who make up 27% of the U.S. population. They make up 75% roughly of our hepatitis C prevalence. And of those who are living with hepatitis C, roughly 75% do not know that they're living with it. Not only because they think that they don't have high-risk behaviors in the past, but because there's just sheer lack of health literacy. So in terms of what is going on the ground, the fact is that people do need to know their status. Physicians and the healthcare profession need to have the support so that once they do receive positive test results, and they will, they need to know what to do and how to support those patients. And the fact is that there is certain plans in place, and I have provided a 2-sheet thing, information of certain action steps, and there are entities such as the CDC, the United States Preventative Service Task Force, and whatnot that provides very clear steps for what to do and how to do to increase awareness. And so with that, the fact is that given the budget climate and healthcare in itself, patients, we need to be empowered to take advantage of our own health and learn. And so we need to be able to ask for the test itself. So in terms of the impact of the disease, I talked about the number of people who are undiagnosed, but the fact is that because this is a chronic blood-borne virus, not only can it be transmitted very easily, it's 60 times more infectious than its cousin of other blood-borne of HIV, and so it's extremely infectious. And so what that means that the impact is that it can be not only preventable, but you can be passing it on to your family and friends. And so, what we say is that if you had an infection, that A, could be preventable, B, that you could transmit to your family and friends, C, decreases quality of life, B, with certain, or I guess D at that point, I'm going out of order, if you, with certain behavioral modifications, you could actually slow the progression of this disease, not to mention the fact that there's a cure. Who, at an individual level and at a legislative level, would not want to make impact with that? And so part of what this is it is eradicating some of the stigma about who should be tested and who shouldn't. And the recommendations are that baby boomers do receive a one-time test, and high-risk individuals, including veterans. Part of the reasons that veterans are at risk, and for those of you who were enlistees before 1992 in universal precautions, they would line up enlistees in terms of vaccinations, go down the line and boom, 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 and vaccinate. Huge way for transmission, whether you gave plasma while you were in college maybe, or you had a blood transfusion. These are huge ways of transmitting this virus. And so when you look at this as a bigger picture, as a public health infrastructure, not only are hepatitis A and B preventable through vaccine, but hepatitis C is curable. And in my lifetime, I believe that we can eradicate this disease state in the world, and especially in Georgia, and then, of course, in our country. And I do want to say that among African Americans, 1 in 10 African American men born between 1940 and 1960 are living with hepatitis C. Majority don't know it. Now, if we break that down between African American men between 40 and 50, it's 1 in 13. And if we break it down between 50 and 60, it's 1 in 7. So you aggregate that, and it's 1 in 10 African American men, 40 to 60, are living with hepatitis C. Most don't know it. Again, preventable, curable, with certain behavioral modifications. There are easy things that I can do. I'm not a physician, that I can educate people. And so part of why we're here is to ultimately help your legislature figure out how to best approach this in the state of Georgia. Got a really great sort of image here. It's on the first page, but I want to talk to you about, again, based on those conservative estimates of the number of people living with hepatitis C. I want to read that more than 100,000 baby boomers living in Georgia are infected with hepatitis C. More than 150,000 have hepatitis C. And to put that in perspective, you could fill 2 Georgia domes with residents in your state who have hepatitis C, and still 7,500 Falcons fans would be left in the parking lot. For those of you who are not sports fans, I am a sports fan, but for those of you who aren't, for all of your residents living with hepatitis C, if they decided to form their own town, their own city, it would be the 4th largest municipality in your state. And so the fact is, people are living out there, things need to be done, and we are seeing manifestations of end-stage liver disease that are happening from undiagnosed hepatitis C. This is happening in liver transplantation, liver cancer, ascites, varices, and you name it, decreased quality of life and death. I saw one of these. I don't know if I should keep going. Okay. And so the fact is I'm a social worker. I want to give you action steps of what to take. Here I am, and we're telling you, oh my gosh, this is terrible. People are dying. There's something we can do about it. But what are the next steps? And the fact is that you can easily go to the United States Preventative Service Task Force, which has given recommendations around one-time screening for baby boomers, those born between 1945 and 1965, and then other high-risk populations, including veterans, including one-time drug users, intranasal drug users, not just IV, people in the medical field, because the fact is hep C is also very transmittable just in the healthcare industry. So that's the majority of, I could talk for hours and I could stand on this table and cheer about it, and I won't. But what I'm going to tell you is that this is happening in your state, and there's easy things that we can do to help save costs, cost-saving measures, cost-effective measures to help prevent unnecessary death from hepatitis C.
Thank you so much, Ms. Wolf and Dr. Holcomb. We'll now open it up for questions from members of the committee, and I believe, Dr. Beverly, you wanted to be first? Oh, that was just a, okay, nervous tick. All right. Representative, I can't hear you. Wilkinson. Chairman Wilkinson.
Thank you, Mr. Chair, and thank you all very much. This is just fascinating and so forth. Now, I'm a classic baby boomer, and so you've really gotten my attention. Retired naval officer, so I didn't go through those. They gave us our shots individually and so forth, but I did see exactly what you were talking about, particularly in recruiting command. I'm curious, the test, what is the test?
Great question. I'm going to take this real quickly. So,
The first test.
okay, go ahead, sure.
No, you want to know what the test is. See, the problem with diagnosing hepatitis C is you have to distinguish acute hepatitis, resolved hepatitis, and chronic hepatitis. Let me explain. If I test you and you have hepatitis antibody, that antibody, that's the antibody test, and that's the screening test. That means that you somehow have been exposed to hepatitis in the past, and your body has made antibodies to that hepatitis virus. Okay? So that screens. So you're positive. Now we don't know, were you infected in the past and one of the lucky 20% who was able to resolve his or her infection without any treatment, anything being done whatsoever? Are you one of the unlucky 80% who goes on with chronic viral hepatitis C? Or are you an acutely a newly infected person? In order to look at that, we have to look at your symptoms, your liver function tests, and another hepatitis test, which is a test for the virus itself. It's called the HCV RNA test. It's actually testing hepatitis RNA in the blood. If we see that, we know that you're actively infected. Whether you were infected would be more likely in your or my case many years ago, or whether you're infected recently, as would be the case we would think with younger people. That requires a doctor to look into, what you've been doing and what your symptoms are, et cetera, et cetera.
That you draw blood.
And one thing I'd like to say, and this is from a patient advocate perspective. So many people go to the doctor, they say, oh, I'm fine. They checked my liver enzymes, I'm fine. But the fact is that you have to, at this point, you have to specifically ask for a hepatitis C antibody test. The physicians will test your ALTs, but if you have an increased ALT, which is a liver enzyme, that may or may not be an indication of active infection. And so it's a two-step process, which is first, depending on if you're in a physician office or community-based organization, there is a rapid point-of-care test, 20 minutes, where you can get to find out, just as he said, if you have antibody positive. If you are antibody positive, you need to go on to the next step, which is a confirmatory test to say, yes, you do or you don't have active infection in your blood. And so it is a two-part test. And the scary thing at this point, which is where we can take action, is that right now the onus is on the patient to ask for the antibody test. Physicians know about this, but we know how much physicians have to do. We know what's out there. And so time is of the essence. And so being able to empower patients to say, hey, I may or may not be at risk. I'm part of the cohort. Can you please give me an antibody test?
Great. Thank you.
On a practical level, a lot of healthcare systems, not Kaiser Permanente yet, but Geisinger and Henry Ford Health System, they have tickler systems. So the doctor, when the patient comes in and is of a certain age, is reminded, hey, you ought to test this person for hepatitis C. So, I mean, there are a number of practical and not that difficult things we can do to identify people. And then once we've identified them, then we can actually start working, to get them into care and get them treated.
Thank you, Chairman. Representative Clark.
Thank you, Mr. Chairman. Thank you for bringing this before us. I watched a very good friend of ours who passed away from hepatitis C, and he got it through a blood transfusion and was exactly in the age range that you mentioned. You mentioned that it's very curable, or that it is curable. What's the rates of that are being able to be cured? I mean, I thought it was low a few years back. There were some harsh drugs that would, in a small percentage, might cure it. Is that still the case?
No. Well, let me put it this way. My wife got we were in Egypt. My wife got infected with hepatitis C from a blood transfusion. She's a classic case of someone who was infected in 1985-86, and she lived with it for 15 years. She had depression, fatigue, joint aches, nausea. She didn't know what was going on. Fortunately, she's an astute nurse who asked her doctor to test her for hepatitis C when he said, let's test you for HIV. And sure enough, she was positive. She took the treatment, which until recently was 48 weeks of once-weekly injection with pegylated interferon and ribavirin. She was actually cured, as are indeed about, say for the sake of argument, about 50% of people taking the old treatment. What's so wonderful about the new treatment is it's 12 weeks, not 48 weeks. It does not require injections. And it's a lot easier to take. I mean, she was incapacitated. This is like chemotherapy. So new patients that we identify now can take pills for 12 weeks and they can be cured. It'd be hard to mention another virus infection that we can cure.
Can be cured, but what's the percentage of those that are cured? Is that the
Well,
85,000 program?
Now we think with the new therapies, 95% or more.
That's on clinical trials. So, I mean, and part of the issue of clinical trials is showing amazing results without these more toxic drugs. And so that's, you have another question.
Is insurance covering this?
So this is a huge challenge. This is lots of going on in terms of the patient assistance programs, lots going on at the federal level in terms of what's going to be included in formularies. So cookies haven't crumbled yet, fallen to really see where we are, but we're working very hard to do that, and there are definite, very robust patient assistance programs from the pharmaceutical companies to ensure that these individuals are getting the drugs. Part of just want to answer in terms of a science question, because as my social work brain, this is important, why hepatitis C is curable and say HIV is not, is because it's what's called an RNA virus versus a DNA virus. And so when the virus replicates in your body, it does not replicate inside of your cell. So that's how we can actually, in very layman's terms, that's how we can kill it, is because we're not getting inside of your cell. It's on the outside, and we can eradicate that virus from your blood system.
How far in the advancement of the disease can we cure it? This person, died 5 years ago.
Anytime. Other than if they're really moribund, if they're really an extremist, then they can't be treated. But anytime before that, anybody with cirrhosis, this scarring of the liver, who's relatively medically stable, even can be treated, and certainly people at any stage before then can be treated.
And even if transplantation would happen.
Okay, I have one more question, unless I think we're down. Representative Broadway.
Thank you, Madam Chair. I know in working with patients that this is a comorbid condition with HIV patients. Are there any programs as far as education and prevention that run parallel with HIV education and prevention throughout the state? Of course, prevention would be the ideal thing, but then looking at a treatment option is also an ideal.
So I'm going to answer it from the patient perspective first, then I think the CDC perspective would be great as well. So there are roughly 25 to 33% of individuals living with HIV are co-infected HIV Hep C. However, there are many individuals as well who are living with other comorbidities, diabetes, you name it. And so there are programs that specifically work with that co-infected of HIV and Hep C. But hepatitis C is a very different beast of a disease than HIV. And so part of our education and what we do is that working with the HIV service providers to really understand the difference of this virus, and that it's not when someone's diagnosed with hepatitis C, whereas with HIV, you need to get into treatment right now, get on drugs right now, antiretrovirals. That's not necessarily the case with hepatitis C. And so there's a huge learning curve amongst the organizations who are AIDS service organization providers to do that.
From a public health standpoint, that the two could be education and prevention programs.
Yes, and as a social worker, here's my concern with that. When I look at my mother, for example, who's a baby boomer, my mother's not going to connect with HIV. She's just not. That's not part of the cohort she is. She's not part of that risk factor. So is it important? Yes. However, the more that we join those, the more stigmatizing we are in terms of being able to bring awareness to this. Because people who are in this room are all, of course, just as impacted by HIV and hepatitis C, but hepatitis C is much more prevalent. And so if we link those together, you're going to lose a lot of people.
Okay. Thank you very much for the presentation. I appreciate you coming. I know it was a distance, and hopefully our weather was a little better than where you came from.
I live in Chicago, so very much so. Thank you.
Okay. So like that. And I will tell you before you get up that we passed the pill mill bill last year. Was it last year?
Fantastic.
So it has been in effect since July 1st of last year. July 1st of last year.
Do you have any numbers for me to take back to my colleagues?
Numbers that we've closed?
Yeah.
No, sir.
All
But
right.
I'm
Okay.
again, Board of Medicine probably they had to register and.
Yeah, we funded that this year.
Okay.
That's fantastic.
Give us a little time. We're working on it.
Great.
Okay. Thank you very much.
However, caring ambassadors can help at the state, local level. We'd be happy to. My information's in here.
Well, at least we now know why we're seeing those billboards that say
Get
if you were born in
baby
before-
boomers, yes.
What's it say? If you're born certain time, you need to be tested for.
If MASH looks familiar to you, or
Of course.
things like this, yes, get tested.
All right. I'm not one of those baby boomers. So I missed it by 2 years. Yes. What? Just a moment. Can you turn on Representative Kids?
I know Chairman Wilkinson indicated he was a baby boomer, and I know Chairman Reiner is a baby boomer, but they look so different from the eyes up.
We're the same age.
Okay. All right. Well, our meeting just got a little bit shorter. Representative Knight has asked for this to be pulled at this time, House Bill 606, and people had asked for an addition. It was another one that involved nursing homes and continuing care properties where you went in and could live independently, went to assisted living, and that Representative Peake was trying to get that on, and there seems to have been, we said that people were in favor of it, and then all of a sudden there seems to be major opposition, so I've asked them to try to go away and see if they can work out stuff for another date. So we just got a lot quicker. So I will call his name? Carl. Call Representative Rogers for House Bill 9, that would be the substitute to House Bill 971. And I will tell members of the committee that we had a meeting. There were approximately 30 or more people at that meeting that were involved in this. Representative Rogers and I listened to all the things, and I think that Betsy will tell you that we incorporated most of them, and we seem to have satisfied everybody except one group. And you have a thing on your desk, a letter, and it's from people in that group. So, Representative, go ahead, and you might want to tell them the changes.
Can you hear me okay?
Got it on. Can you hear, Representative? No.
Test. Okay.
Okay.
Okay, I was just going to give a brief summary, and then we can go over the changes.
Okay.
Lead council will probably help since we've changed so much.
Okay, Betsy, you want to go down and sit by Representative Rogers, since you're gonna walk them through the changes? Pardon?
Oh, you want me to go to do them? Okay. All right. I'll kind of hit the highlights, and then if anybody has any questions about details, we can do that.
Okay.
Starting on page 2, on line 39, that's a new definition, the healthcare practice or facility. The original bill just referenced hospitals and physician practice settings, and then we kind of had introduced some other terms. So in an effort to sort of standardize things and also capture everything that we understand the intent was, that definition was added.
Betsy, that word that everybody had trouble with was healthcare facilities, or they felt that it was too vague.
Yeah, I think we had medical facilities, and we didn't define it. So this is supposed to sort of capture, everything, and hopefully pretty clearly.
And make it more specific.
Right. Compared to the one, we've had numerous iterations. So dietitians were added. I think pharmacists were added since the last version. There various others were kind of in and out at different times. All right, so yeah, that's right. Acupuncturists were added.
You mean acupuncturists get a doctorate? Apparently.
Well, I don't know if they get a doctorate. Well, I guess they do. Not necessarily, but they're in the list of, if they are in a practice with any other healthcare professional on the list, then they have
tell
to
what
wear the
they
identifier.
are.
Right. So then moving on to page 3, some new language starts on 79 where they have to have an identifier. One provision was added that if they have a lab coat or something else that identifies them by licensure level, that could comply with that requirement as long as it had their name and license sort of embroidered or somehow
their
on it.
Identification of what they are.
Right. Let's see. Line 85, that language was reworked a little bit. That's actually line 82 and on line 85 were new since the last, I think, version that was pre-meeting. So that, if there's the requirement for wearing a name tag does not apply if a physician or a healthcare professional is in an operating room or other sterile environment. And then line 85 is sort of a similar thing if there is some safety risk if the person wears an identifier that has their last name on it, possibly.
So that would be like, I think the psychologist came and were represented and said that sometimes it's not advantageous to put your whole name or in a psychiatric setting or something like that.
Right. And I think they mentioned the corrections
system and all, so that was in for that.
Let's see, on line 91, that's the provision that requires healthcare practitioners to post in their office. I'll rework that language a little bit to say the reception area, so that if you have a clinic or something like that, or a physician practice or whatever it is that has numerous types of licensed healthcare professionals, that you could put a general sign in the reception area saying we have PAs, we have physicians, whatever it is.
So rather than like the last one where each one would have had to be listed with their license number, this would just say, this is a multi-specialty group of people working together, and then patients, if they want to know, then would be able to know that there's different levels or different specialties
Right.
working.
The last sort of major change to the language is on page 4, and starting on line 109, that paragraph 5, and then the paragraph below it, 6, is a new paragraph. And these are the paragraphs that basically say, okay, here's all the requirements, and then we say how they apply. So basically, it was intended to sort of clarify, because apparently the language before that I had was confusing to some people, or it was, anyway, I was trying to kind of make that a little clearer. So to clarify that it only applies in a healthcare practice or facility that has more than one type of healthcare practitioner, but then carves out in paragraph 6 that if you're a dentist, however, it only applies if you're practicing in a hospital, the name tag requirement. And similarly for the chiropractors and optometrists, it only applies if you're practicing in healthcare practice or facility where there's a physician or an osteopath.
Right. And I will tell the committee that that is on the direct request, and Aubrey's shaking his head, of how the representative for the optometrist wanted it.
Okay. So those are the major changes.
Okay.
In my recollection.
Okay. Questions for Betsy or for Representative Rogers? Who we got? Okay. Representative Hawkins?
Yeah, Betsy, going back to that line 42 on page 2, it says any other institution licensed.
Mm-hmm.
What other institutions have you left out? I mean, I can't think of anything.
Well, that Chapter 7 is the licensing authority that DCH does, rather. I think
Okay.
home health agencies might come under there.
Okay.
Hospices, that kind of thing. There's a couple of other, entities that we don't specifically list that may fall under here if they had a facility that had more than one type of healthcare practitioner.
Okay. In this line 82, I understand that you're taking it out of the operating room.
Right.
Yeah, that is a little late to ask someone's degree if you're already in the operating room. I mean,
Way to go.
I mean, your chute hopefully is already open by then if you jumped out of
Let
that
me tell
plane.
you, if I see you in the operating room, I'm sure I'm going to ask. Since
I'll
you
have
are
my hat on with my name,
With your-
Ms. Chairman.
Okay.
I think that's it. Thank you.
Yeah, that's right.
Representative Beverly.
Right, thanks. Couple quick questions. Number one is on line 74. I just want to make sure that I understand this. Healthcare practitioners shall wear an identifier during all patient encounters. That refers to everything that follows that. Now, all patient encounters, there are instances where you're going to encounter a patient and you're not going to have your coat on. I mean, in my practice, specifically, we have a lab, we have a sterile area. There are places where you go in and out of your practice, and it could be a multidisciplinary practice that has that as well. So I'm a little afraid that all patient encounters, I mean, it's pretty restrictive to every time I meet or engage with a patient, I should have a name badge on if I'm in a multidisciplinary space. I can see how that could present a problem. Second question, so I want to hear your thoughts on that as well. How do we get around that, and who actually determines if there's a violation with that specific encounter?
Dr. Beverly, I don't see the problem that you see, but I'm not an optometrist like you, but I'm that patient that comes in, and I hope you're an optometrist when I come in there.
Me too.
So you wear a name tag now.
Yeah, up here I better. But back in my practice, I don't, and because we have.
Are you in a multi-specialty practice?
No, but sometimes I do go to multi-specialty practices, and where the issue becomes, let's say for instance someone comes in pre-post-op cataract surgery,
right,
and you're in that room and you don't happen to have on your coat. I may be an optometrist who's absolutely prepared to deal with that issue, but I'm in violation of that section, and so we have optometrists who are against this, obviously, and I'm sure if we added other folk into this, you would see where you're going to have a patient encounter where you may not have that name badge on, not because you directly got rid of it, just because of the way these practices flow. Somebody sees someone, you go in, you're taking sutures. I mean, there's a bunch of stuff that you're doing in those spaces. So that's pretty much why we have a issue, but I'm sure that may cross the board as well.
Well, my suggestion is for you to vote against the bill if you have a concern against it. I know you voted for the ethics bill last year that requires a name tag. So You
Yeah.
can't have it both ways.
Well, you can you can't have it both ways, but you certainly can think about in a real world operational setting where you're
Right.
practicing as a professional to think about how you actually govern yourself in those spaces.
Well, I'm worried about 54,000 constituents that you have, I have,
Right.
about the patient and their family members. So,
Yeah, I'm
And
with you.
Dr.
on that as
Beverly,
well.
let me see if I can help on them. If there's a problem, you get reported to your board, right? Am I correct? And I think that the boards have a discretion to whether to follow through or not. I don't think the intent of this, and the optometrists were the only ones out of that meeting that still had a problem. And the only reason that they give me is this: we don't want to wear a name tag. And so I don't think anybody's trying to nitpick you on that. I don't really think if you're going from one place to the other, somebody's going to turn you in. It's basically just trying to help patients know who's treating them. So, I mean, it really, nobody is after the optometrist at all. This bill was not written to be against the optometrist. It was written for patient care. Thank you. And I appreciate your questions, but like that. Representative Clark.
Thank you. Thank you, Chairman. It says two questions. On line 76, healthcare practitioner's name. I know we had a discussion last time about full name versus just last name. Does that leave it open-ended where they can put what they want, or does it allow them to avoid full name?
the purpose of it was show the doctor's name and the practice he's in. So, does that answer your question?
Does it require a full name though, or just did we address that concern in the meeting after the last committee meeting?
Okay, if you look down on line 87, I think the 86, 87 identifier shall not be required or may not be modified by amending or concealing the last name of the practitioner.
Okay, thank you. Thank you for helping me with that. And then lastly, is there any appropriations for these businesses whose doctors are losing their name tags like I have, and I know a handful of us at least have to go back into the speaker's office for replacement?
You have until January 1st, 2017 to do that. So.
To find it?
Okay.
You're moving
Chairman.
anyway, isn't that correct?
Thank you, Chairman.
Thank you.
So, I was thinking we could send them to Diane in the office to do that. Representative Watson.
Thank you, Madam Chair. Chairman Rogers, I want to applaud you and everybody. It sounds like y'all went above and beyond the call of duty there in your meeting.
Chair lady did a great job, and everybody was at the table.
I mean, it sounds like all the questions that, I had concerns.
Sure.
I don't have concerns now. And to Representative Clark, you can put the name, your degree, on your lab coat, and hopefully we're changing our lab coat every, pretty frequently, and hopefully we got more than one lab coat there, and maybe more than one name badge too. So I must say I'm impressed with the work that's been done. Thank you.
Thank you, and Representative Clark, I will, and for the board, there was a provision in there which probably would have included lab coats, but I had Betsy spell it out because I think it's what you'll find. The hospital pharmacist wears a lab coat, and when he goes out of the pharmacist, and the doctors and the PA and the nurses all wear it, and they have it on there. So I made sure that it said their lab coat, so they would know that they wouldn't have to have another name tag on that. We've tried to work through the problems on this, and I appreciate the people that came. And it wasn't quite as long on a Friday afternoon as it was on the Pill Mills when a different group got together, and we spent 3 hours trying and worked out everything for the Pill Mill group. Okay, here we go. Representative Kidd.
Thank you, Madam Chairman. As you and I talked on Friday afternoon, in Millersville, when I was back in Millersville Friday, I saw my very best friend in Millersville, who happened to be an optometrist, and y'all know who he is. So I presented this question to him and showed him the bill and so forth. He said, I have no problem with it whatsoever. I showed it to my internist. He had no problem with it whatsoever. I showed it to my hospital administrator. I have no problem with it whatsoever. That said, Mr. Chairman, at the proper time.
Okay, thank you, Representative Kidd. Representative Reinders.
Thank you, Madam Chair, and thank Chairman Rogers for the corrections. You could have used that argument about the ethics bill prior to the corrections, and I still would have thought it wouldn't have been analogous of apples and oranges, because if not, we wouldn't have been able to make it a better bill.
True.
So intellectually, I'm going to do a little downfield blocking for my friend, Mr. Beverly, the optometrist. But I do have a question in regards to the sanctions. There's still a part of me, and you're right, I can just vote no.
Sure.
I've been known to do that anyway. But there's a part of me that says we are still giving a board the right to sanction someone because they didn't wear their name tag, their lab coat one time. That still is a possibility, and that concerns me to a certain extent. That to me there should be a little history or whatever before we start doing that. And I don't think there's a fix for that, but there's a part of me that I don't think that's the kind of big government gotcha kind of stuff that you stand for.
Correct.
Thank you.
Representative Reinders, if you would like,
I don't know how to fix it.
Well,
but there's a part of me that bothers me a little
we
bit.
do have a Senate. I'm sure that if the bill moves forward, that Representative Rogers could work with you on trying to find something that could be corrected and could be changed in the Senate. I don't think boards are really interested in that kind of piddly
There's
thing.
nothing that prohibits it.
Right.
I understand the chairman's concerns with licensing boards thoroughly. So.
Okay, right. Does that have to do with real estate license at one time?
No.
Oh, when you missed it and couldn't renew, I don't want anybody to think you did anything wrong with the real estate board. Okay.
The chairman did a study committee with licensing board, and we've all been involved with licensing boards.
Some things we think is kind of silly and shouldn't be done. That was the point.
Correct.
Okay, Representative, since we're at a late time, would you be willing to work with him on if it makes it out of this committee and over to the Senate on the floor for?
Yeah, I don't know how to, at this very moment, I don't know how to fix his fix, but.
But you're open to it?
Sure.
Representative Harden.
Thank you, Madam Chair. I was just following the same thing, and I appreciate the fact that y'all have taken a lot out of it that probably would have been very hard for everybody to comply with in a standardized form. What would you think about, and probably it would be on just an occasional basis, that a person didn't have a lab coat on or encountered a patient, just to require a verbal interaction with the patient as to the degree of the person treating the patient?
Well, Representative Harden, let me tell you where I'm coming from. I've been in situations 4 or 5 times where a professional came in to see me and said, "I'm a doctor," with no ID. And what kind of doctor are you? I didn't ask that person a question, but this is what you're running into in mainly hospital settings, with hospitalists today and Medicaid issues, and it's just, the patient should have the proper knowledge of an ID of a physician or practical nurse or whomever it may be, and the loved one there supporting that patient. You probably never been in that situation, but I've been in it several times, and this is just, a Patient Protection Act.
And I understand, and I'm not trying to say.
And I've had the verbal, but I have no verification. In fact, the picture ID, most hospitals have picture IDs. This does not require a picture ID.
Right, and I know most people are already in compliance with this, but
That's
I was just
correct.
thinking about that occasional time when maybe the physician didn't have his lab coat on. If he just said, "I am Dr. So-and-so, I am an internist, or I am an ophthalmologist," or whatever.
Well, there may be occasions this may happen.
Maybe the licensing boards could put something like that in the regulations.
Correct. They probably already have it in there.
I'd hate to see somebody get arrested just because they had to see a patient didn't have.
I don't think they'll be arrested, but maybe a slap on the hand.
All right. Okay. Thank you.
Representative Wilkerson.
Thank you, Mr. Chairman. I'm just trying to get my arms around this. And I think back to my annual eye checkup, July 5th this year. The ophthalmologist and her family go to church together, sit together a lot, and, you know, friends and so forth. And she comes in with a couple of assistants. I have my glasses off, my eyes get dilated, and I get moved out to an area to wait to come back in. Without my glasses now, I couldn't read the name tag anyway. I mean, having it in advertisements, cards, everything, I completely understand that. Sure. But I'm just trying to find a practical situation.
Yeah, I refer back to House Bill 142. You voted for, I voted for. Making everybody else that's licensed around us as far as governmental affairs, you know, picture ID. So to me, it's on the patient's benefit. I understand that your eyes are dilated, but you recognize them before they're dilated too. So. With a different age, your assistant came to get me. Well, I'm trying to work through this. Well, I can take a name tag and stick it up to here when my eyes are dilated and can see it. So our eyes are different, I guess. So.
Okay.
You're a little bit older than me too, if I remember right.
What do you say? What did I miss? Representative Barr.
Thank you. This might be a little more technical, but the Professional Licensing Board, just wondering if I'm reported, because I'll be honest, I forget my badge quite often when I come to the Capitol. If I forget my badge, when somebody's upset with me, they report me. Does this go on my record as a doctor? How does that part of it work?
It could go through a process. That is correct. It could. And as we discussed Friday, and Madam Chair Lady, you may have to help me. I think we understand now they already have rules and regs in place that would fall under that licensing board. So a complaint, just like I can file a complaint on you right now, and it has to be checked out. Doesn't mean anything's going to happen. But yes, there is a process probably already in place.
Okay. Representative Kidd.
Yes, ma'am. Just very briefly, it's not a question. There's a substantial difference between a PhD doctor psychologist and an MD doctor psychiatrist. There's a substantial difference between a PhD doctor of optometry and an MD doctor of ophthalmology. And you can go on down the list of various professions. And I have to agree with my cousin up there who's presenting the bill. The patient deserves the right to know which one he's talking to.
Thank you.
That's your cousin?
We are.
Okay, last question, Representative Kaiser.
Thank you, Madam Chairwoman. I guess I just want to express my concerns as well, along with Representative Wilkinson. Because I see the ethics bill with the requirement of badges as more of an issue of giving us access and allowing the right people in places where they're supposed to be. And I have no problem with this bill whatsoever in a hospital setting. I still can't get a level of comfort. And I guess if I had a letter from everybody in private practice saying we support this with the exception of the optometrists, I'd be a little more comfortable. But to me, I just can't quite, I'm just not there. And I am extremely concerned about patient safety. So I guess, just going on the record to say that. And I think maybe there's a different way to do this.
Well, let me say, Representative Kaiser, we have done everything I know to do at this point, unless we pull the bill. And I don't think that's the intent I wanted to do. Until you experience the situation, you would understand it. And I wanted, Representative Barr, I wanted you to go back to line 118. If you'll read that, a healthcare practitioner who intentionally violates. So I think, if he just totally refused it or she would totally refuse it. So, but back to Representative Kaiser, Kaiser. Okay, excuse me. My apologize. I like Kaiser better, but anyway. This is about patients in the hospital or doctor's office or nursing home, and your constituents. There's no way to appease everybody on this issue. So, but I think we're 99% there when you say, Madam Chair, as far as.
Seems to be. And how many other states have passed it?
I said 15 last Thursday, but that's been corrected to 18 now. So.
Yeah. Similar bills.
And by the way, we took out the color coding, so you don't have to worry about color coding. So.
Okay. Pardon?
I have a little bit of color blindness.
Oh, Representative Clark.
It is I, Mr. Rogers.
Oh, okay.
I'm so honored to have you as my seatmate, and I learned so much from you. My only concern, again, is to share with Chairman Reinders about the consequences, and also the fact that I would be so much more comfortable if it were in the hospital setting. And those are my two concerns about this bill. Otherwise, it is an excellent bill. And
Well, you have multi-specialty doctors' offices, too, which are big. They're not as big as a hospital, but they're just as big.
So, I mean, okay. Representative Rogers, would you like, I take it that you would consider nursing homes hospitals, too? I mean, would you like to consider that they do it in nursing homes and hospitals?
I have no problem with it. We thought we had it worked out before, but
and nobody brought that up of all the people who, okay. Well, I mean, what makes the difference in a doctor's office?
we're talking about big doctor's office too, so.
Yeah. What? I know. I don't know whether Betsy would that be to entertain that.
I mean, we can revise that definition on line 39, but that's going to make some of the other language in the bill not work very well. I mean, we can do that, but I think it would need a little bit of a rewrite. We talk about office, so some of this language won't make sense.
Is it something?
I can do this, Madam Chair. If my seatmate trusts me, I'll try to correct that in the Senate. If that makes you feel more comfortable, I'm gonna give you your candy back you gave me. I'm sorry.
There's not another gentleman I would trust more.
Okay.
You told me that earlier today.
Okay. In that case, Representative Kidd, you're recognized for a motion.
If anyone like to make a motion to pass.
Okay, I have a motion do pass. Do I have a second? Okay, I have a motion do pass and a second. Is there any further discussion? Everybody in favor say aye. Aye. And opposed, no?
No.
Okay, I'm going to have to take a hand vote. Everybody in favor say aye.
Aye.
Okay. Okay, and I've got one down here too. All right. Hold your hands up.
So we got to change it on?
Okay, how many? Okay, everybody opposed.
A loud group, wasn't it?
Okay. Okay, the ayes have it, so the passes. Thank you very much. And we will, Representative Rogers, be looking to help you with the rewrite on that bill. Okay. What? What? Oh, okay.
What if when you talk to him, he does?
Okay, where are we? Okay, what do we got? Okay, Representative Kidd even got shorter. We're withdrawing House Bill 15, House Resolution 1528 also. And so we're ready for a Senate bill. Do we have a senator in the room? Ah, Dr. Burke, this is your first time. Okay, guys, don't be too rough on him. This is Senate Bill 273. Although I don't know why you should get a pass, Dr. Burke. This is the first time over here. I better behave myself. I might have something come before the Health Committee over there.
With your permission, I will say y'all have a lot more fun in your Health Committee than we do.
Good. I think that's called go to your room. Just on the other end. The lobbyists are acting up behind you. It's okay. I'm just calling down the children. And Nelda, it wasn't the dentist lobbyist. It's okay.
Because your magnetic charm personality, Madam Chair.
That they were acting up? I'm sorry, Dr. Burke. Go ahead.
Thank you, Madam Chair. I'm bring forward Senate Bill 273, and the number is LC 335373S. In a nutshell, this bill establishes a maternal mortality committee that will be under the Department of Public Health. This bill was actually brought to me by the department to bring forward. It basically allows the department to study the reasons behind maternal mortality in our state. As the bill states, Georgia currently ranks last in the number of maternal deaths, which obviously is not a good thing. And with my background as an obstetrician, this is something that I feel very deeply that we need to study and try to find answers to why we're not doing as well as the great state of Georgia should, and try to make recommendations to improve that throughout the state. This will be in conjunction with the OBGYN Society and the CDC. Be glad to answer questions if any of the members have questions.
Questions for Senator Burke? Representative Reinders.
Thank you, Madam Chair. This is just is any idea, is there a cost associated with this, Doctor?
None.
Okay, thank you.
Representative Wilkinson.
Okay, thank you, Madam Chair. Senator, I can't read your name tag.
Did you read it?
And that's for, yes, I can say from last year, right? How about an ophthalmologist? We just want to play fair here, an even playing field. Okay, are we going to get serious now? Oh, okay. Are there any other questions for Dr. Burke? Sorry, it doesn't normally go this way, but apparently we're just getting a little spacey as it gets close to day 30 over here. Sorry, sir. They probably. I'm sure in the Senate it's much more senatorial-like. Okay. It's getting bad. What is the committee's?
But, Madam Chair, at the proper time, I'd like to be recognized. Motion.
This is the proper time.
Okay. I'd like to motion to pass.
Okay, I've got a do pass motion, second. Got lots of seconds. Thank you. Is there any more discussion on the bill? Representative Rogers?
Why are we ranked 50th? Did you come up with that, or who told you that?
The Public Health and CDC told me that.
Okay. You didn't know that on your own, though, I guess.
I knew we were not doing very well.
Okay.
Well, that brings a question to my mind. Senator Burke, isn't one of the reasons that we rank so low, let me see if I can pull this up, is because maybe we keep statistics through the maybe second year of life or first year of life or something. In many countries, in many states, only do it, or they do it longer or vice versa, whichever way, so that we have a different measure.
Well, I think that's always the case when you're comparing states. I mean, apples to apples, and I don't think there's any way to completely make that accurate to the 100%. And frankly, I really don't care. I mean, one death, I think everybody
Thank you
here
very much.
would say is too many. So I think what we're trying to do is understand why we're having them and what we can do about it,
Right.
whether it's 1 or 1,000.
I agree, Senator Burke. Is somebody from here from Public Health that knows the answer to that question?
There are a couple
Internationally,
of folks
do they have different standards and all? Okay, can you come over here and tell us who you are? And I mean, I just get tired of when they rank us across the world saying we're so low when our standards are different. And I just read that somewhere. Can you just tell me how we're different? And
Madam Chair, I don't have a specific answer to that question. I think you were absolutely right, though. I mean, there are different metrics used with different time periods. I think the CDC's comparison, though, is a little bit more apples to apples. You know, and I've seen us range anywhere from 45 to 50 on that range, depending what metrics you use.
Okay.
So I agree with your frustration for sure, but we definitely still rank in the bottom 10 in the country. So.
okay, we definitely need to improve, and I appreciate the senator bringing this. Okay, Representative Watson, you had a question?
No, I just we got it passed and seconded, and let's
call the question. I call the question. Everybody in favor of the passage of? Let me see. Okay, Senate Bill 273. Say aye. Aye. Everybody opposed? No? You've got it, Senator. You in a hurry to go? Get over to the Senate with the new colleagues? A little bit longer over here. Thank you very much.
Thank you.
Okay, and is that it? We got anything else? That's it. Thank you very much to the committee.